All right, get ready for a deep dive. We're tackling cardiac tamponade today. You sent us this YouTube video, a lecture, Cardiac Tamponade Podcast, with Dr. Ross Prager Diagnosis, Echo Signs, and Life-Saving Management.
Catchy title, huh?
Well, it's on the DrBarai channel, and it's a pretty dense medical lecture, We thought we'd break it down for everyone, pull out those key takeaways.
Make it a bit more digestible and maybe, a little bit more engaging, too. Medical lectures, they can be a bit dry sometimes.
Yeah, for sure. So we'll get into the fascinating bits, practical stuff,
Absolutely.
All right, so first things first, what even is cardiac tamponade?
Well, the classic way to define it is it involves fluid building up in the pericardium.
Pericardial.
That's that sac that surrounds your heart. And then, it starts squeezing the heart. But the thing is, the real problem, it's not just the fluid itself. It's what this pressure does to your organs, to how they function. Dr. Prager, he really emphasized that in the video.
So it's not just having some extra fluid in there, it's the consequences of that fluid.
Yeah, it's like a domino effect. The fluid, it causes pressure, and then that throws everything off.
Gotcha.
And here's where it gets interesting. Cardiac tamponade. It's not a simple yes or no kind of diagnosis. It's more like a spectrum, right? You can have mild cases, maybe just subtle symptoms, but it can also be life-threatening. If your heart can barely pump, that's serious.
Yeah, that's scary. Dr. Prager really drove that point home. He was saying that just focusing on how much fluid's there, that can be misleading.
Right.
If the pericardium's been stretched over time, it can handle more fluid. It's not just the amount, it's the context.
Absolutely. Clinicians, they can't just look at the size of the effusion. Got to think about the whole patient history.
Right. And then he talked about venous congestion.
Oh, yeah.
Early on, the problem might be more about blood flow backing up rather than the heart, struggling to pump forward. Blew my mind.
It's like a traffic jam in your veins.
Yeah. Your system's getting hit from all sides.
Exactly. And this is why it's so tricky to diagnose, right? You've got the patient's history, you got to do a physical exam, and then, of course, imaging.
So ultrasound's the big one here, right? Dr. Prager, he was really enthusiastic about point-of-care ultrasound. Called it a lifesaver.
Oh, he loves it, yeah. He showed all these cases how ultrasound can help you spot different signs of tamponade.
Like that swinging heart sign. That was fascinating.
Yeah, you see the heart actually moving a certain way. And it lines up with specific changes on the ECG, too.
Wow, yeah. So it's not just seeing the fluid. It's using that image to, guide your actions in real time. Crazy.
Exactly.
That's incredible.
And then he had those cases using TE.
TE. Hold it. For those of us who, aren't cardiologists, what's TE?
Well, imagine a tiny ultrasound probe, and it goes down your esophagus, so it's right there, close to your heart.
Ah, okay.
Gives you a much clearer view, especially for the back of the heart. What he was showing with the TE cases, it's that sometimes this fluid buildup, it's localized, like a pocket of fluid, just in a specific spot.
So it's not always like this even spread of fluid.
Nope. And the TE, that's crucial for finding that spots, especially after heart surgery. You might have bleeding around certain chambers. So it's tricky, like finding a leak in a maze of pipes.
Wow. So once you've figured out what's going on, how do you manage it? Is it always a rush to surgery?
Well, not always, actually. And Dr. Prager, he spent a lot of time talking about how the treatment, it really depends on the patient and how sick they are.
Makes sense.
He kept saying tamponade is a spectrum, not one size fits all.
Right. He was clear about that.
Now, if someone is really crashing because of tamponade, you got to drain that fluid ASAP, usually with a pericardiocentesis.
Right. Get that fluid out.
But sometimes surgery might be the better choice right away, like in trauma cases where there's a lot of bleeding. You made a good point about that. Sometimes you're better off going straight to a thoracotomy or a pericardial window. Those are surgical procedures. Instead of trying a myocardiocentesisis first, saves time, precious time.
Yeah, in a trauma situation, every second counts.
Exactly.
So what about those less dramatic cases, the ones where someone's not, about to collapse? What did he recommend for those?
Well, he talked about using IV fluids to try and boost the blood volume, counteract that pressure from the effusion.
Okay, so fighting pressure with pressure.
Kinda, yeah. And sometimes you got to use medication to raise blood pressure, support circulation.
So there's a lot of different options depending on what's causing the tamponade and how severe it is.
Exactly. He did warn against being too aggressive with diuretics, though. Those meds that make you pee more?
Yeah.
Especially if someone might be borderline for needing that pericardiocentesis, getting rid of too much fluid too quickly could actually backfire.
Okay, yeah, that makes sense. So finding that balance is key.
It is, and for inflammatory effusions, like what you see with pericarditis, he said anti-inflammatories can help.
Ah, okay, so you're treating the inflammation itself, not just the fluid.
Right, and if it's autoimmune, you might need steroids or immunosuppressants.
Really depends on the root cause.
Exactly, but whatever you do, close monitoring is key. You got to be ready to do a pericardiocentesis if things start going downhill.
Right, so it's like always be prepared.
Always, and he pointed out that pericardiocentesis, it's not just about treatment. It can help you figure out what's causing the effusion, send that fluid to the lab, infection, inflammation, even cancer sometimes.
Oh, wow, so it's a diagnostic tool as well.
Two birds, one stone.
Cool. What about the research side of things? Did Dr. Prager talk about anything, new and exciting happening in tamponade research?
He did. He's actually doing research on venous congestion and tamponade.
Oh, that's interesting.
Yeah, especially for patients with smaller effusions, chronic ones, who might not have the typical symptoms, but they're still having organ problems.
Yeah, like we were talking about earlier. It's not just about the heart pumping. It's about the backup, too.
Exactly. It's a hot topic. He also mentioned there's still debate about the best timing for intervention.
Oh, so like when to do that pericardiocentesis?
Yeah, especially in the less severe cases. No easy answers. More research is needed.
So even with all we know, there's still a lot to learn.
Definitely. But, before we wrap up, Dr. Prager had this great piece of advice. He said, don't get too stuck on those strict definitions and criteria. Remember, tamponade is a spectrum, and patients, they can present in all sorts of ways, even if they don't perfectly match the textbook.
So it's not always clear-cut.
Nope. He really emphasized looking at the whole picture. The patient's history, what you see on the exam, all of it.
It's about seeing the whole patient, not just a set of symptoms.
Exactly. And even a small effusion, it can cause big problems if you ignore it.
So trust your gut. If you're worried, don't be afraid to dig deeper, even if the echo doesn't scream tamponade.
Absolutely. Always be advocating for your patients.
Well, there you have it, our deep dive into Dr. Prager's lecture on cardiac tamponade, diagnosis, imaging, treatment. We covered a lot.
He really knows this stuff, and he's such a good teacher. I loved how he kept coming back to that idea. Tamponade is a spectrum. You got to individualize patient care.
Yeah, for sure. This deep dive should give everyone a good foundation for understanding this complex condition. But, as always, the learning never stops.
So keep those brains buzzing, and we'll catch you on the next deep dive. This was a really good way for Dr. Prager to introduce some of the key things you look for on an echo when you're thinking, maybe tamponade.
Right. He really walked us through the images step by step, which was helpful, for actually visualizing it.
Yeah, for sure.
He started by pointing out the pericardial effusion itself, which is, usually that dark area you see on the ultrasound. But he did say sometimes it can be brighter, like if there's blood clots in there.
Oh, yeah, he gave us that visual mnemonic to remember the difference. He said, think of a swimming pool. Clear water, it looks dark, right? But throw a bunch of sand in there. It gets brighter.
Okay, yeah. That's a good one. I'll remember that. So what else did he point out in this case?
Well, this patient, they had a really diseffusion. You could see the heart kind of rocking back and forth in the pericardial sac. He called it the rocking heart sign.
Yeah. I remember that. It was pretty dramatic to see. And he mentioned that this rocking motion, it actually matches up with a specific finding on the ECG called electrical alternans, where the heart's electrical signals, they're changing size as the heart rocks.
It's wild how those two things connect, right?
Totally.
And then he zoomed in on the right ventricle, and you could see how it was getting squeezed during diastole when it should be filling with blood. That's a huge red flag for tamponade.
Yeah, he explained that this is like the main reason tamponade can lead to shock and low blood pressure. The heart literally can't fill up right because all that pressure from the fluid.
Exactly. It's like trying to inflate a balloon inside a closed container.
Yeah, no room to expand.
And it's not just the right ventricle either. He pointed out how the right atrium, it can collapse during systole, which at first seems kind of counterintuitive, right?
Yeah, you'd think it would be filling up during systole, not collapsing.
Exactly. But because the tricuspid valve is closed during systole, the right atrium should be filling up with blood coming back from the body. But with tamponade, all that pressure in the pericardium, it prevents that from happening, so it collapses. Subtle finding, but really important.
Man, there's so many things to look for on an echo when it comes to tamponade.
There are, and Dr. Prager, he didn't stop there. He also mentioned things like variations in the tricuspid and mitral valve flow.
Okay, yeah, that was getting a little advanced.
It is, but basically it shows how the filling of one ventricle, it affects the other when there's limited space. It's all connected.
Right. And then he talked about measuring something called the LVT-VTI.
Right.
Helps you figure out how much blood is actually leaving the left ventricle. He said even if you don't see all the classic signs of tamponade, if that LVOT-VTI is low and there's a pericardial effusion, bad sign.
Yeah, it means the effusion is probably messing with how the heart's working, even if it doesn't look super obvious on the ultrasound. Like you said, what really matters is if the effusion is causing organ dysfunction. That's the real definition of tamponade.
So you could have a big effusion that's not causing any problems, or a small one that's wreaking havoc.
Exactly. You got to look at the whole clinical picture.
All right, so moving on to the next case, remember that swinging heart sign?
The one that helps you find the right spot for drainage?
Yeah.
Well, in this case, you could actually see the guide wire, the one they inserted during pericardiocentesis, the procedure to drain the fluid. It was coming in from the left side of the screen, going right into the pericardium.
It was like watching live surgery.
It was pretty cool, right?
And he emphasized how important ultrasound guidance is during pericardiocentesis. Make sure you're in the right spot, you don't accidentally puncture the heart.
Especially the right ventricle. That's thinner, more delicate than the left.
Right.
Puncturing that, it can cause serious problems, more prone to tearing. So precision is key.
Yeah, you don't want to be poking around in there blindly. What about the next case? That one was a bit more subtle, I remember.
Yeah, this one didn't have all the dramatic collapse and swinging.
Right.
But he pointed out you could still see this the subtle indentation of the right ventricle wall during diastole.
Okay.
Which means it's not filling properly.
Gotcha. And he gave us that handy tip, too, for figuring out if the heart's in systole or diastole. If you don't have an ECG handy, just look at the mitral and tricuspid valves. Closed. Systole. Open. Diastole.
Easy peasy.
Really practical. Especially, in those emergency situations.
For sure.
Okay, what about the case with all the fibrin strands in the pericardial fluid? That one was different.
Ah, yes. That case, it sparked a really interesting discussion about how the appearance of the fluid, it can give you clues about what's causing the effusion. Just like pleural effusions in the lungs, pericardial effusions, they can have different characteristics depending on the cause.
He said fibrin strands, those can be a sign of all sorts of things. Bleeding, infection, chronic inflammation. He said to be careful about just draining the fluid in cases of suspected infection. Might not solve the problem.
Exactly. In those cases, you might need a more aggressive approach, surgery, maybe, to really clean out the infection.
It's not just about getting the fluid out.
Nope. Got to address the root cause.
Okay, now I remember this next one. The patient had a big effusion, but the echo looked totally normal.
Oh yeah, that was one of those trick cases he likes to use. To emphasize that you can't just rely on the echo alone. You got to consider the patient's symptoms, the whole clinical presentation.
He said tamponade is ultimately a clinical diagnosis. It's about how the patient's doing, not just what the images show.
Exactly. If someone's asymptomatic, blood pressure is fine, even a large effusion might not need immediate action.
This is where that clinical judgment really comes in.
It does. It's not just checking boxes. It's putting it all together.
Now, the next case, this is interesting because it challenged the traditional thinking about how tamponade affects the circulatory system.
This was the one where they used Doppler ultrasound to look at blood flow in the carotid artery and the jugular vein during breathing.
Right? Gets a little technical.
It does, but basically the idea is that when you breathe in, the right side of the heart, it should fill up more, which should then decrease the amount of blood leaving the left ventricle because there's limited space in the pericardium.
Okay, so it's like a seesaw effect. One side fills, the other has to empty a bit.
Kind of, yeah. But what they found in the study early on in tamponade, there might be more of a problem with venous congestion, too much blood backing up in the veins, not just the heart struggling to pump forward.
So it's like the plumbing's getting back up on both ends.
Exactly, and that's bad news. High venous pressure can really mess with blood flow to the organs, lead to damage.
So it's a double whammy. Heart can't pump out, and blood's getting stuck coming back in. Fascinating. And it sounds like we still don't know everything about this aspect of tamponade.
We don't. Dr. Prager, he's actually researching this right now, trying to figure out how to better diagnose and manage patients with these smaller effusions, the ones who might not have all the classic signs, but they're having organ problems because of this venous congestion.
Wow, that's really important work.
It is.
Okay, so next up, post-cardiac surgery tamponade. Dr. Prager said this is a whole different ballgame compared to, tamponade in people who haven't had surgery.
Oh, yeah. He explained that in medical tamponade, the fluid usually surrounds the whole heart, but after surgery, the fluid or the blood buildup, it can be localized, like little pockets around specific chambers of the heart.
And that makes it tougher to diagnose, right? You might not see those obvious signs on the echo.
Exactly. He showed a case where they had to use TEE to get a good look. Remember the probe down the esophagus?
Oh, right.
A regular ultrasound might miss those little pockets, but the TE, it gets right up close.
And in another TE case, he showed how tricky it can be to tell a clot from the heart muscle itself. You gotta look really carefully for those subtle clues, like a thin layer of fluid outlining the clot.
It's like playing Where's Waldo, but with ultrasound images.
Yeah, you need a trained eye to see that stuff. He even suggested that TEE might be helpful for trauma patients. gives you a better view compared to a regular ultrasound from the chest.
Oh yeah, he mentioned a study found that TEE picked up pericardial effusions in trauma patients that were missed on the initial ultrasound.
So it could be really valuable in those critical situations where, you need information fast.
He did. He said with trauma cases, sometimes you're better off going straight to a thoracotomy or a pericardial window, which are surgical procedures. Instead of doing a pericardiocentesis first, it can be a real lifesaver.
Yeah, that makes sense. So what about the less urgent cases, the ones where the patient is stable? What did he recommend for those folks?
Well, he talked about IV fluids, try to increase the blood volume a little, counteract the pressure from the effusion.
Right, right.
And sometimes you need medications, to raise the blood pressure and help the circulation.
But he did warn about being too aggressive with diuretics, the meds that make you pee a lot.
Right. Especially in patients who might be borderline for needing a pericardiocentesis, getting rid of too much fluid too quickly, it can make things worse.
Yeah, it's all about finding that balance.
It is. And for those inflammatory effusions, like with pericarditis, he said anti-inflammatory medications can be really helpful.
Okay, so you're treating the inflammation, not just the fluid.
Exactly. And if it's an autoimmune issue, you might need steroids or immunosuppressants.
So many different approaches depending on the cause.
Yeah, for sure. But no matter what, close monitoring is key. You got to be ready to do a pericardiocentesis if things start to go downhill.
Always be prepared.
Always. And, he pointed out that pericardiocentesis isn't just for treatment. It can actually help you figure out what's causing the effusion in the first place.
Oh, how so?
You can send the fluid to the lab and get some clues about what's going on. Is it an infection, inflammation, sometimes even cancer?
So it's a 2-for-1.
Exactly.
Treatment and diagnosis. That's pretty neat. Did Dr. Prager talk about any new and exciting research in the world of tamponade?
He did. He mentioned how researchers are starting to look more closely at the role of venous congestion in tamponade.
Oh, right, like we were talking about earlier.
Exactly, especially those patients with smaller chronic effusions who might not have all the classic signs, but they're still having those organ problems.
So much we still don't know.
There is. And he also said there's still debate about the best time to intervene. When exactly should you do that pericardiocentesis?
Especially in those less severe cases.
Right. Tough question.
More research is needed.
Definitely. But before we wrap up, I thought Dr. Prager had a really great piece of advice. Don't get too hung up on those strict definitions and criteria. Remember, tamponade, it's a spectrum, and patients can present in a lot of different ways, even if they don't perfectly match what you see in the textbook.
He was really emphasizing looking at the whole picture.
He was. The patient's history, their exam findings, all of it. And even a small effusion can cause big problems if you don't catch it.
It's about seeing the whole patient, not just a list of symptoms.
Exactly.
Trust your gut. If you're worried about a patient, even if the echo doesn't look too bad, keep digging.
Couldn't agree more. Always be advocating for your patients.
Great advice. Well, that's it for our deep dive into Dr. Prager's lecture on cardiac tamponade. We covered a lot of ground. Diagnosis, imaging, treatment, even a little bit of research.
Dr. Prager's a great teacher. I really appreciate how he explained everything so clearly and emphasized that individual approach to patient care.
Yeah, for sure. This deep dive should give everyone a solid foundation for understanding this complex condition. But of course, the learning never stops. Keep those brains buzzing, and we'll catch you on the next deep dive.